Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. It's our pleasure now to start our second session, which will discuss the current issues in immunosuppression. And our first speaker is Dr. John Fung, who is the chairman of surgery in the Educational Institute of Cleveland, Ohio. Dr. Fung is a well-known person in his career, and he has more than 14 positions, academic positions in the field of transplantation. He published so many papers in the field of transplantation, and today he will be talking to us about the temporary issues in immunosuppression, discussing the overview, current practice, and future strategies. Please, Dr. Fung.
Well, thank you, Mr. Chairman. Thank you for the, I'd like to thank my friend Faisal Shaheen for the opportunity to be here. I was able to attend the first GCC conference almost 10 years ago. So hopefully I'll make the third one if it's going to be 10 years from now. But I'd like to today spend a little time talking about, I think, some new advances in immunosuppression. But for the purposes of background, what I thought I would do is just give you a brief summary of where we are now in the practices in immunosuppression in the United States, at least, for various organs. So here you see the small chemical synthetic immunosuppressive agents listed at the bottom, and the biological agents used in clinical immunosuppression on the top. And you can see the increasing number of compounds that have been in clinical trials. There are many more that have been in trials that are not shown here that have been dropped as potential immunosuppressive agents. But you can see that there is a concentration of new drugs in more recent years. Part of this is driven by the understanding of the mechanisms of T-cell activation. And these include the three signals that are involved in T-cell activation. Signal 1 through the T-cell receptor, signal 2 through the co-stimulatory molecules that are essential for T-cell activation, and then signal 3, which are growth factor, cytokine-driven proliferative responses. And listed here are some of the agents and their known pathways that inhibit these three signals. So what has the implications of these new drugs been? Well, clearly, as shown in the next slide, the amount of the combinations of immunosuppressive agents that we're currently using have dramatically lowered the incidence of rejection, shown in red, and increased the survival of patient and graft survivals. Here, these are kidneys. So most trials expecting a 90% one-year graft survival and 10% rejection rates for kidneys are really pretty much the gold standard. For livers, we have seen a similar drop in rejection rates from 85% under azathioprine and prednisone to 10 to 15% now utilizing induction antibodies with tacrolimus, MMF, and prednisone. So I thought I would just spend a few minutes talking about the different practices in induction, maintenance, as well as tapering. This is a composite of the types of induction agents used in all of solid organ transplantation. You can see here that there is a variability of the utilization of induction, with the lowest organ being livers at about 20%, and the highest being in pancreas transplantation, about 85 to 90%. Of the agents that are utilized, the most common induction agent is, in fact, the rabbit antithymocyglobulin, which is thymoglobulin in the United States, and then followed by the use of the IL-2 receptor monoclonal antibodies, and then following that OKT3, which is no longer available in the United States. Now, why do people use induction? Well, there are a variety of reasons. Patients that are highly sensitized, repeat transplants. And in the cases of extrarenal transplantation also to delay the use of calcineurin inhibitors in order to allow kidney function to recover before the introduction of calcineurin inhibitors. This is a trial that we conducted recently at in our own center, which is the pivotal pilot study, which will now be utilized for a larger study in the United States. This looked at 3 arms of a pilot study of a tacrolimus maintenance therapy introduced within 48 hours with MMF and steroids, rabbit antithymocyte globulin, 2 doses at 3 milligrams per kilogram, starting on day 10 after liver transplantation, and then a 3-dose thymoglobulin study starting again at day 10 for a 4.5 milligram per kilogram total. And without going into the rejection rates, which were slightly higher under the rabbit antithymocyte globulin 2-dose, what we still see is a retention of renal function shown at the very bottom in red at 1 year with best renal function GFR at 88 cc's per minute for the 3-dose compared to 2-dose at 72, compared to the control tacrolimus alone at 51. And so this strategy has been validated in other organs, and the concept of delaying calcineurin inhibitors to preserve long-term renal function is something I think that is worthwhile considering in future trials. Regarding maintenance immunosuppression, clearly the agent tacrolimus now as a calcineurin inhibitor is become the gold standard with almost 90% of patients on that. Nevertheless, cyclosporine is utilized either in certain protocols for a variety of reasons, including the potential use in patients with nephrotoxicity associated with tacrolimus. Mycophenolate mofetil is now being utilized in about 90% of 90% of solid organ transplant patients, whereas you can see in blue the corticosteroid use has gradually fallen. The most common combination, in fact, in almost all organs is tacrolimus, MMF, and corticosteroids as maintenance therapy. If we look at the actual specific use of these drugs according to organs, and you can see the color coding at the bottom, pancreas transplantation has always utilized tacrolimus almost at 100%, with the lowest being heart transplant in 1998, gradually increasing to 70 to 75% by 2007. Parallel to that was the utilization of tacrolimus in lung transplantation, which started at 40% in brown in 1998, now in about 90%, and then liver transplant and kidney transplants in purple and green, respectively. Similarly, MMF, the utilization is also shown here with the early adopters of MMF being in kidney and pancreas transplantation and gradual increased utilization in the other organs. Here, the downward trend of corticosteroid use is apparent in the liver and kidney protocols. And interestingly enough, the corticosteroid-sparing protocols are rarely used in lung transplantation when one might think that the bronchial healing is important. Nevertheless, pancreas transplantation, where the known diabetogen effects of corticosteroids has already seen about a 40% reduction in its utilization. So I mentioned why we would avoid or reduce corticosteroids. These are the known side effects associated with it. We've heard about bone demineralization. How can we utilize or avoid corticosteroids? Well, induction agents have also been utilized in order to initiate immunosuppressive agents without the use of corticosteroids. If we elect to wean immunosuppression, corticosteroids, you can see that there are some potential downsides. This is a corticosteroid withdrawal protocol that was done at the University of Cincinnati compared to a standard low-dose corticosteroid protocol. While graft survival was no different, shown in the left, the incidence of acute rejection with early withdrawal, shown in green, is higher in that group compared to a low-dose corticosteroid group, shown in blue. In addition, other studies, the Freedom multi-center study, did show that corticosteroid-free had a biopsy-proven rejection rate of 31% compared to corticosteroid withdrawal at 26% compared to low-dose corticosteroids at 15%, suggesting that there is a beneficial, if you initiate corticosteroids, there is a beneficial effect compared to corticosteroid withdrawal or free protocols. However, there are subgroups of patients where corticosteroid avoidance is beneficial, and these are pediatric patients where clearly corticosteroids are associated with retardation of growth. In this study, there was no negative impact of corticosteroid avoidance in a pediatric population. Other studies have clearly shown that withdrawal, even in these children, leads to improvement in growth, as shown in the Steve Dunn study from 1994. What other drugs have we tapered or weaned? Well, clearly we know that renal failure after solid organ transplantation, extrarenal transplantation, the incidence of renal failure increases over time, with intestinal and liver transplantation rates at about 20% by 5 years. But even in heart and lung transplantation, the incidence is 10 to 15%. We had heard at the 12 o'clock session that calcineurin inhibitors are toxicity as a cause of renal failure. In kidney transplantation patients is very common. This is also true for liver transplant patients, where calcineurin toxicity was shown to be found in almost 3/4 of patients in liver transplantation. And this is the New England Journal paper showing almost 90% or more of patients having a long-term calcineurin-associated nephrotoxicity on biopsies. So calcineurin withdrawal has also been advocated in more recent studies. In this, using MMF as a replacement, the kidney transplant protocol of eliminating cyclosporin, however, was associated with a higher rejection rate, both acute and chronic, although the overall patient graft survival was similar. In another study, the CAESAR study, where cyclosporin withdrawal versus cyclosporin low dose versus cyclosporin standard dose, one can see that the lower line, the BPAR, or biopsy-proven acute rejection rates, were higher in the cyclosporin withdrawal compared to the two groups where cyclosporin was retained. Another set of agents that have been proposed to be able to allow calcineurin withdrawal are the mTOR inhibitors. The Symphony study then compared cyclosporin with MMF and corticosteroids to a daclizumab induction with low-dose cyclosporin and MMF versus low-dose tacrolimus and MMF and daclizumab induction, and finally a sirolimus low-dose with MMF and daclizumab. You can see that while there is really no difference in allograft survival, there is clearly a difference in the incidence of rejection. Here, low-dose tacrolimus MMF with daclizumab induction had the lowest rejection rates, whereas the mTOR inhibitors at low dose had the highest rejection rate, and cyclosporin doses in between. Patient survival did not differ, but graft survival was significantly higher in the tacrolimus treated group compared to the cyclosporin and sirolimus treated group. And the GFR, interestingly, in spite of the use of mTOR inhibitors, was higher in the tacrolimus treated group, perhaps reflecting the negative impact of rejection. And that's the biopsy-proven rejection rates. Another study, which is the Rapamune maintenance. This were patients that were induced on cyclosporin, sirolimus, and then had cyclosporin withdrawn, showed a significantly, interestingly in this study, better graft survival. And while there was no difference in biopsy-proven rejection, protocol biopsies did show a reduction in chronic allograft nephropathy, and in this group, in this study, a better GFR in the blue, in which were sirolimus and corticosteroid maintained patients as compared to those who were sirolimus and cyclosporin. So in contrast to the study I showed you before, this study suggested that reduction of cyclosporin and withdrawal was associated with improvement in renal function. Another study, which was a large study, basically looking at the ability to convert to MMF and from MMF and calcineurin inhibitor to MMF and sirolimus, showed that there was a beneficial effect, a 5% increase in GFR when a worsening in GFR in those patients that were maintained on a calcineurin inhibitor, and a slight improvement of 1% in patients that were switched to sirolimus. And this was a kidney transplant study. The parallel liver transplant study, however, showed a significant improvement in renal function in the sirolimus treated group, with a 22% improvement in GFR compared to a 6% improvement in GFR compared on the patients maintained on calcineurin inhibitors. However, sirolimus was associated with a higher dropout rate due to side effects, and this is just a list from that study looking at the different side effects associated with sirolimus. And there has been also interest in looking at the mTOR inhibitors in liver transplantation from as an induction. You will hear later in this session, in this conference, the use of everolimus, Dr. From the French group looking at everolimus in kidneys. So I'll just give you a quick summary of the everolimus study. This data will be presented at the AASLD in November. So you're seeing results of a study that have not yet been shown to anybody else. This was a 3-arm study where liver transplant patients were induced or started on tacrolimus and corticosteroids with or without MMF. And 1 month after transplantation were randomized into 3 groups: to continue tacrolimus at standard practice, to eliminate tacrolimus with increasing levels of everolimus, or to maintain patients on everolimus and tacrolimus at low levels. And you can see these curves. These are biopsy proven rejection and graft loss death, a composite endpoint. You can see that one group has a dramatic drop in the ability to be free of these side effects. And this, in fact, was the tacrolimus elimination group. So that patients at 2 months after transplantation who began the process of tacrolimus weaning, by 6 months after, had a cumulative rejection rate which was significantly higher. This was suggested that to be due to the negative impact of tacrolimus elimination. This arm in DSMB was stopped, and the 2 other arms, which was tacrolimus control and tacrolimus low dose with everolimus low dose, continued. And you can see that, in fact, the combination of everolimus and tacrolimus had a better control of rejection than even the tacrolimus control group. But more importantly, and which I think is a revolutionary finding and will potentially impact the way we manage our liver transplant patients, is the recovery of renal function in patients who were transplanted on tacrolimus and steroids, then converted to low-dose tacrolimus and low-dose everolimus. You can see their renal function by GFR was a staggering 10 cc's per minute better throughout the entire 12-month follow-up period. Next is the utilization of co-stimulatory blockade, and in particular the LE829Y, also known as belatacept. This is a CTLA-4 Ig fusion protein which inhibits the co-stimulation. We have known from previous studies that in the phase 2 study with belatacept at lower frequency and belatacept higher frequency dosing compared to a cyclosporin baseline, that in fact the acute rejection rates were no different between the 3 groups. GFR was substantially higher in the belatacept group, which avoided cyclosporin or calcineurin exposure compared to the cyclosporin treated group. And interestingly enough, the chronic allograft nephropathy was almost half that of the cyclosporin-treated group, consistent with both better control of rejection and less calcineurin toxicity. However, in the follow-up phase 3 study, there was a substantially higher risk of acute rejection, as shown here, compared to the cyclosporin group. In fact, it was already evident by 6 months after transplantation and persisted to 12 months after transplantation, with higher severity of rejection, as shown in this slide, with higher need for a lymphocyte-depleting treatment to reverse rejection. In spite of that, what was found was that in these two groups maintained on belatacept without a calcineurin inhibitor, the GFR rates were substantially higher, 12 to 15 cc's per minute better than those patients maintained on cyclosporin. And even those patients who rejected, shown in the right graph in gray, in the belatacept groups, had better GFR than those patients on cyclosporin that did not reject, the far graph bars on the right. This was associated with better freedom from stage 4 and 5 chronic kidney disease by biopsy, and a lower incidence of chronic allograft nephropathy that was shown in the phase 2 study. Belatacept was also utilized in a liver transplant study in a similar fashion with high dose and low dosing of belatacept, but with the addition of two control groups, tacrolimus and corticosteroids, and tacrolimus and MMF. Quickly to summarize the results, the belatacept group had a higher rate of composite endpoint of graft loss, patient death, and acute rejection at 6 months compared to the tacrolimus MMF group, and even higher than the tacrolimus corticosteroid group. And those patients with a functioning graft were fairly similar, except for the belatacept low-dose group. And interestingly, as would be expected, the belatacept groups that did not have cyclosporin exposure had substantially better, or in this case, almost 20 cc's per minute better than the tacrolimus treated groups. There are a number of new agents that are becoming available for or in clinical trials. I would just highlight 3 of them. One JAK kinase inhibitor, one protein kinase C inhibitor, and a CD2 alefacept monoclonal antibody. The alefacept antibody underwent phase 2 trial as induction agent in low risk kidney transplant patients, along with tacrolimus and MMF. What was interesting was, while there was no difference in BPAR at 10% basically between the two groups and no impact on patient survival or graft survival, what was interesting was that the CD4 and CD8 memory T cell showed a substantial drop. This suggests, inconsistent with its known effect on memory T cells, that perhaps this agent, which did not show any benefit in de novo patients, in fact, should be used in patients that are more highly sensitized. The AEB study, very quickly, there was intended to be utilized with a tacrolimus run-in and then be utilized with the AEB and mycophenolate alone at 6 months after, 3 months after kidney transplantation. And simply just to tell you that there was, during the period where tacrolimus and AEB were both utilized together, rejection rates were quite low. But once the tacrolimus was eliminated, the rejection rates went up dramatically. You can see it went from a control group of 8% to the 45 and 34% rejection rates in the, after the tacrolimus was eliminated. Finally, the protein kinase C inhibitor has been undergone a phase 1 study, and it does look like these patients do have very similar GFR, and this will be tested further in kidney transplantation. So in summary, I hope to show you that the concept of induction therapy, I think, has undergone some changes, and I think its future will be in highly sensitized patients, as well as the ability to delay calcineurin exposure during a period of hemodynamic instability to reduce the vasoconstriction and subsequent decrement in renal function. I think also the other strategies of steroid withdrawal, which we talked about, will be continuing the testing, but has some limitations. The use of mTOR inhibitors, either in place of calcineurin inhibitors or together with calcineurin inhibitors, I think are also of interest. And finally, belatacept, which is an interesting drug, which has some logistical issues because it has to be given intravenously or subcutaneously in the future, and does have limited extrarenal application. So finally, in conclusion, calcineurin-based immunosuppression is still considered the keystone of immunosuppression, and that I don't foresee in the future that calcineurin inhibitors will be eliminated for most clinical units, but in future trials, as we look at the combination of immunosuppressive agents, clearly need to look at other factors such as renal failure, renal function, which I think is will improve the long-term outcome in transplant patients. Thank you.
Thank you very much for this very nice and informative talk. So we'll have about a few minutes for if there's any questions or comments on the talk. Any of the audience have any questions? Dr. Shaheen, go ahead.
John, I enjoyed your talk very much as usual. My question, maybe it is very hard to be answered, but what's the best drug you think that in the future we are going to use as immunosuppressions for our patients, especially from our area? Probably we are different a little bit from other side, and you know better about our patients here.
Well, so I think that belatacept has some very interesting properties, and the fact that you can avoid calcineurin inhibitors entirely is very attractive. Some people will say that the requirement to give it as a parenteral administration rather than as an oral improves compliance, but it does have some logistical issues in how you administer the drug on a weekly, monthly, bi-monthly basis. So I think it will be a challenge for people to adopt that. But clearly it has, as you saw from the renal function data, some true benefits. But really, I think at this point, only limited to the kidney transplant. Now, can belatacept be utilized in a sequential model of calcineurin short-term with a belatacept long-term? Possible. And they may be beneficial in extrarenal organs. I think until that time comes, the induction agents are, I think, something that makes sense. We have been, in liver transplant, reluctant to utilize polyclonal thymoglobulin induction for a variety of reasons, usually due to low white count, low platelet count. But we have utilized it without really very much side effect, and I think some mechanism of delaying calcineurin inhibitors makes sense. I think in this population here, rejection doesn't seem to be as big a problem, so I think a standard tacrolimus MMF without corticosteroids with an induction agent probably is a very effective and cost-effective protocol.
Do you see belatacept can be used with a low-dose calcineurin drugs together? So you will minimize the toxicity of the calcineurin drugs, and you have adequate immunosuppression at the same time.
So I know that Mo Sayegh will be talking about this tomorrow on Thursday, the co-stimulation blockade. Nobody's tested that, and I think that's unusual that it hasn't been tested. It'll be interesting. I think based on animal models, it should be effective, but there are some theoretical reasons not to do it either. But nobody's ever tried it that I know of.
Dr. Nizam, do you have a question?
Thanks, John. It's a very nice and elegant talk. I think in transplant business there is no one-size-fits-all.
Right.
I think we have to tailor our medicine to the patients. One is more sensitized than others. When the question is in racial differences in the states, did you find this more effective when you use like belatacept? And is it available now here or?
I'm not sure that it's available in Europe. It's available in the U.S. It was just approved about 4 months ago. There are some restrictions on how belatacept is used. It has associated with a higher incidence of PTLD, for instance, in the seronegative patient. You know, I don't know. They did not see any differences in race. So the African Americans, which have been traditionally in the United States a high-risk group, had the same benefit as the Caucasians in terms of belatacept. Whether or not this is going to be true for other demographics, I can't tell you. I don't know that.
Yes, go ahead, please.
John, just for very comprehensive presentation. The transfer from MMF to Imuran as a cheaper, yet perhaps just as effective immunosuppressive agent, particularly in other parts of the world.
Right. So there have been a number of studies that looked at MMF to azathioprine conversion and suggested that there is no negative impact. So I don't have personal experience in a wholesale manner. We have converted our hepatitis C patients from MMF to azathioprine because of at least a retrospective analysis that suggested that azathioprine, patients with hep C on azathioprine have less recurrence, but not done on a prospective basis.
Okay, we have a question from Dr. Weil.
Thanks, John.
Okay.
Open the microphone.
Thanks for. Okay. Thanks for this talk. Just a quick question about the belatacept. What do you think about the high rate of CMV infection associated with with the belatacept compared to other medication? And the second question, quickly, what do you think about the data in terms of steroid withdrawal? We have this Canadian study 20 years ago with 10 years follow-up showed that withdrawal is harmful for our transplant patients. We have now this new data, not even 10 years follow-up, showing that you might withdraw steroids on patients, yet even the FREEDOM trial, the rate of rejection was higher, or let's say it was less in the steroid maintenance group. Do you mind to comment on that?
So I guess I would say that at least the corticosteroid withdrawal groups, it's really a quality of life issue. It's certainly not from a financial standpoint because corticosteroids are very inexpensive. But I would say that if you look at the trends of steroid freedom, I didn't point this out in my slide, but in the last few years there's actually been a slight increase in corticosteroid use because the theoretical advantages of corticosteroid avoidance have really not been seen as much as we had anticipated. So I would say that's a first. On the belatacept issue, I think at least at this point, there are going to be a learning curve of belatacept. Very few people have really had any hands-on experience with it. I think that's a challenge for Bristol Myers Squibb is to get the drug out in people's hands so they can actually utilize it. But these have been just the registration trials without really much other hands-on experience.
I'm sure the audience have more questions, but unfortunately, for the sake of time, we have to move to the next talk. So my colleague, Dr. Weil, will present the next speaker.